at some point.
I'm sure he's not going to be too happy about that. I've seen Ben do some dance moves before, mate. So, g'day everybody, and welcome to another episode of Pre-Hospital Nerds. And we are very privileged today to have one of the OGs from Ambulance Victoria, who is going to speak to us today about the future of paramedicine. So, a friend of mine, Ben Meadley, Dr. Ben Meadley, we can actually call him now because he's gone off and done his PhD. But Ben, thanks for joining us today, mate.
No worries. Thanks for having me.
I know you're a very, very busy man, so we will keep this tight. But Ben, can you give us a bit of an introduction to yourself and to what you've achieved and how you've achieved it, and we'll go from there, mate.
Oh yeah, I guess the quick version is I did an undergrad exercise science degree. That was my first love. Got to the end of that, and the real only prospect was a career in probably research in that area, and there wasn't a whole bunch of other employment opportunities. Had a few mates from uni who went off to become paramedics. I followed that. I was unsuccessful in getting into Ambulance Victoria. I worked as a ambulance community officer for about a year or so. Moved to Sydney, worked there for 4 years. That was where I was able to get a job. Worked through the Sydney 2000 Olympics, met a lot of great people, learnt a lot about being a paramedic, and had a great time. But eventually met my wife in Sydney, who was from Victoria. So we eventually decided to move back to our home state. And I was fortunate to get a job with AV. And shortly after that, when we moved back, I did my micro training, probably a couple of years after you did, Matt. And yeah, went off and worked on the road as a micro paramedic for about 4 years before both you and I, Matt, went off to the helicopter in 2009 together. Did that for 15 years and did a PhD while I was there, and a lot of kind of research that I was doing there. Kind of bits and pieces came into a PhD eventually, and then I worked as I guess an improvement scientist or improvement lead for a couple of years while I was still at the helicopter in those last couple of years. And then in 2024, started as the director of paramedicine at Ambulance Victoria, which is a great role where I still remain clinically active. I do 1.5 clinical shifts a week, I would call it. So I do a day rostered on an ambulance that is non-negotiable. So that's a day away from the office, out responding as a micro paramedic, usually in South Gippsland where I live. And then I do a day kind of, I've got my own vehicle, access to my own vehicle to go and just do jobs and go out and see crews I'd like to see. So that might mean I drive to the other side of the state, spend some time with people in a different area or whatever it might be, a bit of flexibility there. But largely my focus in the job at the moment is research, education and guidance of clinical practice for our nearly 6,000 paramedics at AV. 6,000.
We're certainly getting up there in the numbers, aren't we?
Yep, absolutely. So yeah, it's a big service. We're the second biggest ambulance service in Australia. So and one of the big, kind of top 10 in the world as a jurisdictional ambulance service. So it's a big job.
That's fantastic. Yeah, that's a career and a half. And you're still pretty young. But that's exactly correct what you said, according to ChatGPT. I couldn't help. I just said, who's Ben Meadley? You will be pleased to know that he is a fairly well-known figure in Australian paramedicine. He's a paramedic, a researcher, an educator. He's an associate professor at Monash Uni. He's director of paramedicine, mate, and then all the stuff. And he got it right with all the dates and whatever.
Well,
so you
better make sure I'm not full of it then. Hey, at least AI knows what I want about. You can't get caught out. I could have said I was a whole bunch of other things, but I would have been caught out by AI.
Corrected you. But no, mate. So that's fantastic, and you've done every possible job within the ambulance service, haven't you? The first was a community response officer. Did you say? Yeah.
Yeah. So that was those roles still exist at AV, where we have ambulance community officers locally to where I currently live who provide support roles to full-time paramedics, and also often will be the primary response. So at a couple of local areas around the more remote places, there'll often be a double ACO response. Where I did it was at a town called Anglesey on the Great Ocean Road, which it was a bit of a privilege to work there, to be honest. But the model then at that time was 2 volunteer first responders. So with basically they at that time, and this is in the late 90s, they gave you the keys, showed you the defibrillator, and said you'll be right, mate. And that was it. So it was a bit hairy, but it gave me a taste for whether it was the right thing to pursue. And yeah, no doubt, here I am, nearly 30 years later.
Anglesey, mate, what a beautiful part of the world to start your ambulance career in Victoria. Like if I could pack up everything and move down there and afford to live down there, I would be down there in a heartbeat, because it is an amazing place. And as you well know, we stop down there when we go and do the Peter Pub every year, my family. So it's a beautiful part of the world. But so Ben, let's talk about your role. So a director of paramedicine. It's pretty new, and obviously you've only just recently started it. Within Australia, how many other directors of paramedicine do we have? And then just tell us a little bit more about the role and what it actually entails.
Yeah, so New South Wales and WA have a very similar role. It's called something slightly different, but it's effectively the same role. And one of the, I guess, the key relationship pieces in that job is being able to support the medical director in the things that on a day-to-day basis are important to paramedics, first responders, community responders, and all of the clinical staff at an ambulance service. And I speak to my contemporaries in other areas. There's a lot of these roles in the UK as well, and we often speak to people when we're collaborating around various bits and pieces. And often it's a bit of a intermediary, if you like, almost like a translational role between the medical director of an ambulance service, who's usually exceptionally busy, and it's certainly the case for David Anderson, our medical director, who obviously still works clinically in a hospital, does a bit of pre-hospital work, and is involved in executive decision-making as well as clinical oversight of the ambulance service. So exceptionally busy roles. And I guess the role as a big part of it is making sure that the medical director has the support that they need, and probably testing some concepts to see whether they're suitable to the paramedic workforce. David was a paramedic many years ago before he was a doctor, so he's got quite good insights into what the role involves. But even still, as I've got the fortune to still work clinically and speak to paramedics in the field every other day, then you're able to kind of sound out ideas and then bring them back to the office to talk about, bring real-time feedback from the field into the clinical guideline team and the office of the medical director team, and then all the other places I sit. So where I end up sitting on a day-to-day basis is on a number of committees, or chair a number of committees. So for example, our clinical technology and equipment committee was held yesterday, so I co-chair that meeting. I sit on a multidisciplinary team for patient safety reviews weekly. We look at those cases if there's a case to look at. There's not always a case, but that's part of the role, providing subject matter expertise into these situations of patient safety incidents and how we can make sure that we try and avoid them in the future, but make sure we're supporting staff to make sure that they've got the tools that they need to give the best care that they can. I own the scope of practice for paramedicine at Ambulance Victoria, so I oversee the scope of practice matrix and what people are permitted to do within, people would know within all of their guidelines. Usually on the front page somewhere it tells you what you can do. And then it's little kind of branches of all of this stuff. I supervise 5 PhD students with our research director and other people across the ambulance service. So we're doing a lot of research in various areas. So that spans, ultrasound, STEMI care, airway management, physiology of climate change, and how paramedics best support humans in the area of climate change, for example. So a real kind of diverse area. And just taking on another student that's looking at international critical care practice, and then advising to things like the clinical education and continuing education programs that are undertaken each year for our specialist paramedics as well as our generalist paramedics. We work with the clinical support group, Matt, that you're part of, try and work with different parts of the organisation, such as patient safety, continuing education, clinical support, to bring these people together to have common themes of teaching in the field, that face-to-face teaching, but also to try and push into new areas of clinical practice. And that's where you bring clinical practice, education and research together. I guess that's the 3 prongs of the trident, if you like, to make sure that if we're going to say we're going to do something, that it's got a decent evidence base and that we could realistically teach paramedics to safely use those things. And so it's kind of like this Venn diagram of those things almost every minute, trying to work through each of those things. So does the research support what we want to do? Let's go and have a look at some data, formal or informal published data, internal, external, whatever it might be. Is it a reasonable course of action to make sure we can credential and educate paramedics to do these things safely? And also, is it the right thing to do from a clinical practice point of view? Is it the right focus? So in 1975, there was a lot of road trauma. There was a lot of accidental trauma, workplace trauma. If you had a heart attack, there were no cath labs. You had your heart attack, you're in a real pickle. You're going to go into cardiogenic shock. You're going to get really sick. You're going to have to give really significant active care. Today, the care looks different. And we've got more of a medical focus. We don't see as much trauma as we used to. For example, our MICA service and intensive care ambulance services were designed and invented to look after really, really sick cardiac patients and really sick trauma patients. And they look different today. So elderly trauma is, in fact, our biggest clinical area at the moment. So car crashes are not what we do a lot of anymore. We see very few of those. So then we look at the research, we go, what are paramedics seeing? What should we be educating them on? And where should we be focusing their clinical practice? Just to use those two examples. It's just this continual wheel of revising what the right thing to do is, making sure the service we deliver to the community is the right service. Because we had, of those 5,000, 6,000 paramedics, 4,500 of them were specialist intensive care paramedics. It's not what the community needs. So we need to make sure that what we're doing is aligned to the community.
That's great. Mate, things are constantly changing, aren't they? Not only the sort of patients that you see, but the evidence and the tools and equipment available. And yeah, it'd be tricky to keep on top of. But maybe talk for a second about, the fact that you guys are clinical. David Anderson is clinical, is still doing stuff, but in a leadership role here. And yourself, you were saying you do a day a week, sort of always 1 week, a day a week on the road. How does that sort of feed into a leadership role like this? Because certainly in the hospital setting, there'll be people up the top who hasn't seen a patient in some time. So yeah, what's the benefits and challenges with that?
There are a number of things. So, I came off the back of working in the helicopter environment as I came into this job, and had to look at whether or not that was plausible to stay working in that environment, for example. And I really enjoyed working there. But I just don't think that a day a week or maybe even 2 days a week would be enough to be clinically, fitting into what is a very complex operating environment from a patient care point of view. And then logistically, walking into a tail rotor or something because my head wasn't in the game. And others, and Matt, you might say the same thing. You've got to be in that environment working most days, I think, to really kind of have your head space. And as you get older, you forget stuff as well. So you've got to make sure that you recognize when you're at your limit. But working as a intensive care paramedic on the road 1 to 1.5 days a week, I feel like that I can achieve that reasonably. And on the other days, I'm always talking about clinical practice. My morning this morning has been only talking about clinical practice with other clinicians, with David, with other people. So always kind of got the brain ticking over in that clinical practice mindset. In my office time, I very much protect my scope creep out into areas that aren't clinical, because I really do have to make sure that the job has the value for the clinical focus. And then that ties back to my time on the road, because as I said, it's that kind of immediate translation. It is challenging though, because you move when you get, I guess, further down your career into an environment of practicing largely on experience rather than book knowledge and guideline focused knowledge. I'm very heavily reliant on digital support tools in the field to cross-check my practice, which I think is a good and safe way to practice. But, going in 2009 to my first day on the helicopter, I could tell you, who printed the guidelines and what year and what the copyright and patent information was, because I knew that information religiously. Today, that's not the case. So I'm very open to being heavily reliant on the people I work with to make sure that my clinical practice is sound and contemporary, and I welcome that clinical oversight. And it's one of the really important parts of the role is to work with other people and show that, I don't know everything, and the pace of change and the rate of change is enormous in our environment. And it's just, unfortunately, I guess I see that at the office end, all these impending changes coming up, and then you've got to go and translate that to practice, the next week. So there's a number of challenges, like even logistically, there might be a meeting put on my clinical practice day that's really important to go to. So I'll have to move that day to a different day. Unfortunately, there is always a vacant roster line wherever I want to work. So there's always the opportunity to pick up a shift. It's never been an issue, unfortunately, because of the strain on resourcing that is across the health sector. But I tend to try and make it work as best as I can so that I can, give what I need to give to each part of the role, but it's something I'm also very protective of. I guess you could easily find yourself in one of these roles and they go, just drop that day. There's too much going on. You've got too much work to do, but the value is enormous for me personally, but I think to the system as well to be able to, again, just rapidly translate the information. It's so important. And the connection piece between frontline staff and the people who are providing the guideline-based support on all of these things there can be a very big lag there. But I think if you're working in the field and then going back into the office each day, you can make that a little less of a lag and get some kind of real-time change.
And I can attest to your knowledge. Certainly when we joined the Air Wing in 2009, you were streaks ahead of everybody else. And I think you maintained that pace throughout your time at the Air Wing. And, it's evident when you still work on the road that you still have a very good clinical knowledge and are often still 5 or 10 steps ahead of most of the other people that you're working with. And I think as a organisation, we're very fortunate to have you on the road and operating on the road. And I'm sure those people that work alongside you appreciate getting a moment to share some of your knowledge and so forth. Now, guideline changes, mate, they're coming thick and fast. And as an old timer, and as you've already said, it gets harder to remember things nowadays. And so people have sort of expressed that they're getting so much new changes and so much technology that's coming towards them. I imagine that at some point it will slow down a little bit, but I guess where I'm leading with this is, we're talking about this of the future of paramedicine. How far are we going to go? Obviously, we're getting more and more medications that we have. We're getting more and more guidelines that we actually can utilize when we're on the road. And more tools are coming our way. And what's that term that you use for new toy syndrome? I love it. It's
PANTS.
PANTS.
Paramedic acute new toy syndrome. Yep.
Paramedic acute new toy syndrome. That's definitely going in the shorts, Alex. That's a great one.
We still got to write that up.
It's a real issue though, is because, we get new devices on the road and people want to use them all the time. And often that's associated with mistakes as well. But so where are we going, Ben? Down the track, obviously Victoria recently produced their cardiac arrest results. We are doing very well worldwide with our results there. And you've stated within the top best ambulance services in the world. What do you do to get as number one, mate?
It's a good question. It's a really good question. Oh, yeah. Wow. Yeah. Well, from cardiac arrest, we're second in the world behind Denmark. So,
which is very impressive.
Yeah. Yeah. That's great. But we'll all have to go to Denmark and have a bit of a look, I reckon, is the answer. So
there's the Pre-Hospital Nerds tour, Alex.
Love it.
Yeah.
Love it.
Yeah,
we'll
do
Denmark.
that.
Why
But,
not?
Denmark is flat and they speak.
Yeah.
Funny.
So you can tell the Norwegian, he's going
Government.
to have a chip at another Scandi country straight up. He's just going to say they're not that good.
No, they're great.
Fair enough. There's a lot of difference, like I've spoken to Ziad, our director of research, and basically, one of the leading cardiac arrest researchers anywhere in the world about apples and apples comparisons, so we're comparing the state of Victoria with a really centralized medical system versus, a country that's a lot smaller, it's flat, there's different challenges and, could you make an argument that we're actually better? And he's like, well, no, just be honest and we'll go for a statewide approach and we'll still try and be better. And I think that's a good approach. So look, a lot of that comes down to public education. And we're really fortunate to have an advanced system in Victoria of critical care, for example, but it's the good basic care that is the foundation of that cohort, for example. And I think that's something that the ALS cohort, our generalist paramedic cohort at Ambulance Victoria should be immensely proud of. And all paramedics should be proud of that, getting in there and doing the foundational work. And the rest is garnish. Because without the foundational work of good, hard, fast CPR, high-performance CPR, early defibrillation, activation of supporting resources, and of course, the front end of that is the community response of bystander CPR, AED programs, etc. And Good Sam, these first responder programs, those things are without question a major contributor to improved outcomes, but it takes a system to save a life. So if you don't have the first link in the chain, which is that first public access piece versus right through to the critical care piece, you need all of those links to generate these outcomes. You can't just have one of them. And I think that going back to your original question about the rate of change that we see, the guidelines that continue to evolve, it's a very, very different job than when you and I started, Matt, it's nearly 30 years ago, where it was a real focus on doing good emergency care, I guess we'd call it, and then being really kind of professional and supportive around these other areas. what we know from some of the data from our service, but it's replicated across Australasia and no doubt the rest of the world. We have a response rate between 4 to 6% of critical care defined patients. So across the million cases Ambulance Victoria see a year. So it's quite few. We are approaching a mental health response rate of 20%. And so we've got a really strong community obligation in paramedicine to be good at that cohort. We've been good at the critical care for so long, or the emergency care across all kind of groups, probably a better way to phrase it. We've got small specialist groups that are good at critical care, and it's important. There's no question that group is important. But if you look at things like complicated mental health emergencies and even subacute and acute mental health crises, it's really, really important we get really good at that work, primarily for the community and the patients, but also for the system. The system needs that level of support from paramedicine. We are the community link, and we see a good proportion of these patients. And at the moment, we're a bit underdone in our ability to provide the best level of care there. And the solutions may not necessarily be, they'll be multifactorial. It's not just paramedics getting better. It's better virtual support. There's a whole range. We've got a meeting this afternoon talking about all of these things about better virtual support. So we can do in this era of technology. As I see here on my 500 megabits per second internet, which I was talking to you about. These things are achievable. The other thing, I guess, is that we've spent so long in paramedicine say, don't call an ambulance for things we determine are not worthy of an ambulance. But we're the front door to the health system. And the community in your time, Matt and Alex, they've never changed their mind about their perception. A person's own personal emergency is something that they own, and it's a real challenge for us to define that for them. And whilst it strays us away from the work we've historically been tied to, right back to the Knights Templar wandering around Jerusalem looking after sick people, it's been largely that emergency, environment of people who are in peril. The community expectations, I think, of the wider health system are very different today. And it's really opportunistic for the profession. Where there's a gap, and we've got a great opportunity to fill it. So that means being really good at primary and acute healthcare, the ability to refer people, enhance our ability to do good, really comprehensive patient assessment. So you talk about things like, point of care, blood analysis, point of care, imaging. Who knows where that's going to go? There's devices in trial now that are basically a corset that you wrap around. There's a 3D ultrasound. You don't have to do any of the scanning. It does it for you. It goes to an AI interpretation algorithm and goes, yeah, they've got, gallstones. Let's go call VED and see which path we can take. So you don't necessarily have to go, well, let's send every paramedic off to be a sonographer. Let's send every paramedic off to be a mental health practitioner. We can give foundational education around these things, provide great remote decision support, but you still got to give the paramedic some kind of tools at the interface. Like we look at things like the stroke truck, potentially being, we'll wait and see what the science does, but potentially being redundant in the next decade, where you've got these little stroke CT helmets that you can carry around in a suitcase into Mrs. Jones's house and do a head-only, CT and do a remote diagnosis there and then, speak to a neurologist. And for somebody who lives in a rural area where you can't get to a CT and some thrombolysis or a clot retrieval in a timely fashion, that's game-changing. We already look at, and to sound like an old person, when Matt, you and I started, a stroke was a code 2 response. You go to a stroke because you go, there's nothing we can do. You wouldn't even drive lights and sirens. That's right. Yeah, and when you were nursing and all these things, it was the same as heart attacks in the 70s. Push them in the corner and go, hope you go okay, mate. A stroke, hopefully we can get you into some rehab. But today, if you lived in a metro area or outer area where you could access CT or thrombolysis or clot retrieval in a timely fashion, you could have had a stroke on Monday and be doing the gardening on Friday. Said, I had a stroke on Monday. And so that is completely life-changing for people, just unbelievable. It's not a car crash or a major trauma and all these things we've historically defined ourselves with, but the value to individuals that is offered here is enormous. Diabetic care with every patient with a mildly high blood glucose, we've taken to hospital for further assessment for a long, long time. And if we were to, at the point of care, be able to speak to an endocrinologist or an emergency physician with a blood analysis of their electrolyte panel and look at their ketones and look at their glucose, things we can already do, you can seek a very different pathway. There's a trial that's going to start soon in Victoria, and there'll be other trials around the world that look at chest pain patients. 70% or so of chest pain patients that go to an ED are discharged within 4 hours. And at the moment, our easiest thing to do, because of our limited diagnostic capability and I guess our limited risk tolerance around some of these patients, is you could just take them all to hospital so they can get a troponin and work it out. Is that time better spent in the field doing a troponin at the point of care, using a validated tool to do a risk assessment? An ECG, been around since 1904, still one of the most sensitive and specific diagnostic tools that we have. So an ECG plus a risk tool plus a remote consult plus a point of care assessment of their biomarkers, and maybe we'll wait and see if what the research says, we can safely leave these patients at home and identify the high risk ones that need further care and then refer the other people to different things. So it's about thinking really differently about what pre-hospital care means, and not to denigrate from your title of pre-hospital nerds, but it really, pre-hospital implies, I guess, that we're going to take people to hospital. That's as we already know, not always the case. There's a cohort of people that will always have to go to hospital. That's definitely the case, but there's some that won't.
That's what we should be. Change the title, change the logo, get on that. No, look, that's great. Yeah, there's some fantastic thoughts. You were talking about that CT helmet. That shouldn't be too difficult. And in fact, the sort of smart rings that a lot of people wear, that's the same technology as an MRI, I think, isn't it? So,
yeah.
If you could wrap that stuff around a finger, you could wrap it around the head. But hey, to your sort of point about emergency care versus, I guess, all the stuff that people ring for, just to push back, I guess, like if we change the stuff we do, wouldn't that then generate more of that type of work? And I guess like an analogy would be emergency, right? We just saw in emergency department, we had a lot of sort of GP related questions turn up, and a lot of ED doctors didn't really know how to deal with low iron or repeat script or this sort of stuff. And so we employed a GP to work in ED, and of course, the spike in GP-related presentations just went through the roof. And yeah, similarly, like, if response times are struggling pre-hospitally, if we also start getting involved with measuring people's ketones and blood sugar and arranging podiatry outpatient follow-up, and I'm worried that might worsen the response times.
Well, without question. So you'd need to parallel, I guess that's the missing piece, is you've got to parallel that with the appropriate resource uplift. So if you're going to relieve pressure on other parts of the health system, you'd expect then the resource shift. So for example, Ambulance Victoria has one of the largest secondary triage areas of ambulance services across the world. And they're pushing into the space of video-assisted triage very heavily, and they'd love to do more, but they're probably only able to get about a 30 to 40% hit rate, and that's published data on the amount of patients that they'd like to see on video. Because as you can imagine, enormous, complete change in the way you would assess somebody over the phone when you can actually see them. So you're exactly right. You can't do that under the existing model. You have to do it with a resource uplift. But the biggest resource uplift might be something like secondary triage, is where you start that and you push into that space a little bit area. And I think, Queensland Ambulance do this really well, having visited their virtual care centre, which is a multidisciplinary virtual care centre where they've got a big control room, for example, with a whole range of different practitioners, including physiotherapists and psychiatrists, psychology, and a range of other specialist practitioners that can give that advice. But usually what it means is that the paramedics get there, they work out that there is no life-threatening emergency, they refer, and they're able to leave. The problem is, of course, is that those services, once they prove value, they get used more and more and they become under strain themselves. If they're under-resourced, they need further uplift. So you're exactly right. You can't do all of those things under the business as usual arrangements, or it would cause enormous strain in the system. In saying that, I think there's been a number of initiatives over a period of time where the health system works together to try and work out where the best answer lies. And I think that's part of the future, is making sure that ambulance services work with health services to understand where the effort must be spent to stop to reduce ramping, for example, there's a local hospital in Victoria that's been in the news quite recently in Frankston. They've reduced their kind of off stretcher time down to 22 minutes on average. Yeah, that's an enormous change from what it was previously, and that's the system kind of working together to work out a range of different priorities. So I think I'm hoping that we continue to work together to solve a lot of these things, but you can't get past the fact is that you've got to get out to do the jobs that are there. And if you don't have enough people to do it, then it puts more pressure on the system.
Yeah, Frankston Hospital, hats off to you and applaud to you. You've done some amazing work down there. Certainly the morale of the staff that are working around that area has lifted an awful lot because of the effort that's been put in by the hospital. So well done, Frankston Hospital. It'd be great if everybody else could follow in that footsteps, but everybody's got their own restraints and so forth, which predict and control what they actually do. So you mentioned clinical trials about chest pain. That would be fantastic if we could do something like that. A lot of people love tools as well, and we spoke about your pants syndrome as well. I've heard that Ambulance Victoria potentially having ultrasounds coming in the future. I don't know whether that is something that's definitely going to happen, but what are your thoughts about use of ultrasounds? Alex briefly mentioned there that there is the potential with all these new tools that people forget the bread and butter of what we do, and that is transporting some people to hospital who actually need that as their form of treatment rather than us overdiagnosing at scene. I'm sure you're aware when you've done cases in the helicopter and you've used ultrasound, you've diagnosed things, but then you spend a little bit of time doing it, not too long, but you spend time doing it, which adds to your scene time. But then at hospital, that same scan gets done again when you get to hospital. Yeah. What is the ultimate benefit of having machines like that and tools like that for us in the out-of-hospital environment, the out-of-hospital nerd environment?
Well, it's a good question because you've got to be able to take those three things I said earlier: research, clinical practice, and education, and then answer that question. So Jake Donovan, one of my paramedics at Ambulance Victoria, is one of my PhD students, and he's trying to answer this exact question around clinical utility. So is the juice worth the squeeze? Is it actually worth doing? So I'll give you an example of ultrasound. We don't know is the answer. You and I were there for the introduction of ultrasound at Air Ambulance in 2015 or so, and had been doing it for a long time. There's a reasonably high teaching and credentialing burden to be good at it. That's the first thing, and that's variable. And we wrote a paper on that in 2017. It's from anywhere from a couple of hours into a couple of years that a paramedic might undergo an ultrasound training program. You could be a very basic operator right through to a sonographer level training. And then the question is where does the clinical utility lie? For me personally, the thing that was a game changer are twofold for me, and that was lung ultrasound to determine the presence or absence of pneumothorax. So Matt, when you and I started the helicopter, you fly from Melbourne, you go over the Alpine National Park and land at a town on the other side of Mount Hotham or the other side of Mount Bogong, whatever. And somebody's got they've got SATs of 91 and a GCS of 14.5 and a chest injury and a heart rate of 101 and a BP of 99 and some decreased breath sounds, and you've got no ultrasound, and you go, and the pilot says, we've got to go back at 8,000 feet.
Yep.
And so you go, well, clinically, from the best information, fallen off a mountain bike, banged his chest, got these vital signs picture. I maybe can invent some subcutaneous emphysema here. Is that what it is? I'm not quite sure. So you go ahead and decompress the chest. And then you get to the receiving hospital and there's a bit of plastic in that person's perfectly good lung because there was never a pneumothorax. That would be inexcusable in today's environment, because once we got ultrasound, you just simply ultrasound that person and go, well, you do or you don't have a pneumothorax. And it was pretty reliable. It's one of the more reliable ultrasound assessments to detect from a clinical practice point of view. And you just go, well, I will or I won't. That was the decision that was made. The other big one for me, in a case example, I rolled up to a job on the side of a mountain somewhere, motorcyclist down, broken femur, otherwise uninjured, really, really difficult IV access, in a lot of pain. We were not far away, and we'd only recently acquired ultrasound in our practice. And the paramedic on scene was hamstrung by being able to actually get decent analgesia, and maybe the blood pressure was a little bit low, I can't recall. So he was about to put an intraosseous in, which kind of seems counterintuitive to cause pain to relieve pain. And, they still obviously have their place and they're an important emergency access tool. But in this case, that seemed like just a little bit of a step too far for this patient. But the paramedic was cornered. So that was my first ever attempt at ultrasound-guided IV access. And sure enough, put the ultrasound on. There's a gigantic, cube fossa this big and straight in with the cannula. And we avoided having to do that procedure of the intraosseous. And that changed my life from a patient-centered point of view. If we can avoid suffering, and avoid and get more rapid IV access without kind of blindly poking or having to use an IO, then that's great. So that is what is valuable. That's not just the critical care environment. That's in all environments. So for generalist paramedic practice, once these devices are affordable and you can get them out into the general practice, and we've got a pilot generalist paramedic site in the east of Victoria about to trial this in the ALS paramedics, the what's called the vein identification method. So they won't guide the drip in, they'll just identify the vein and then go with a standard technique as a little bit of a trial. They're just going to borrow a device for a while and have a bit of a look at that. So we are starting to push into the space there because I think the vascular access thing's a no-brainer. There's no further research required in that regard. It's something that you could teach most people to do. Even just that technique of going, there's the vein, because I couldn't see it superficially. Now I know that it's there and I can go ahead and have a pretty good chance of getting it in. The big one for me that's unanswered is the abdominal component for critical care patients. So if you have a patient who has, EFAST is the general trauma assessment, so extended focused abdominal sonography for trauma, and the E part of it is extended. So that's brought in the lungs as well when we started doing that as well, and that kind of is the standard protocol. But if you had a patient who crashed their motorbike into a pole at 100k an hour and they got a BP of 60 and a heart rate of 120 and a sore abdomen, and if you did an ultrasound and you didn't find any free fluid, they're still getting a bag of blood, aren't they, Matt? Yep. And, all the other things, checking for pneumothorax and stopping the bleeding, all the other things, but ultimately they're probably going to get a bag of blood. If you have a patient, the same patient, and then they crash into the pole at 100 k's an hour and their BP is 120 and their heart rate's 80, and you find free fluid on their abdominal component of the scan, you're not going to give them a bag of blood. The clinical utility at the moment in the pre-hospital environment to guide transfusion, for example, is fairly limited because it's largely going to be the clinical assessment that you use to guide the treatment rather than this particular diagnostic modality, not discounting its value in the chest and the IV access. Where we want better capacity is to be able to take that information of the scan, which I still think holds value. And you said it earlier, at the moment, you do that scan, you ring up the hospital and go, hey, I'm half an hour away with this person and I think there might be a positive, abdominal free fluid scan. They're going to go, yeah, cool story, Matt. I'll do it when I get here anyway, because I don't believe you. But if we were able to transmit the images in real time, that's a different story. And other services do that. And other services also have such a robust training program. If they call a positive EFAST in the field, then they part the C at their end of their journey so that they go through the emergency department much quicker because they recognise that the expertise is there. So there's a couple of things there. The ability to digitally transmit some of that imagery would be awesome. So the hospital can go, I know what I'm seeing, I know what I'm getting. We spoke earlier about the importance of visual information as part of a clinical diagnosis. And then on top of that, working with the hospital and our education systems to say, am I confident that a paramedic scan is of a high standard for this group of patients? And would I use that information to mean that they move through ED, let's say straight to CT, for example, or are they just going to stop and redo the scan? Because at the moment, if we're doing this scan twice for the same outcome, to your point earlier, it seems like a waste of time. So we've got to answer that question, and Jake will answer some of those questions in his research.
Yeah, they're very good. I agree, Ben, with certainly my use with the scan. I certainly found ultrasound of the chest very valuable, and certainly vascular access. I could have done with one the other day for a patient that I had who ended up getting an intraosseous needle when he went into VT because we could not get IV access. But if we had ultrasound, it would have been very beneficial for him. So
you'll have to hold a bake sale. Get yourself one.
Well, not too bad with cooking, so we could work something out there, I'm sure.
I'll buy something for your bake sale and contribute.
I just, to touch on, you said something interesting earlier, Ben, about the sort of, ambulance having tried to market that, we only want you to call 000 for emergencies. And then, later on, you're talking about 70% of patients with chest pain get sent home in 4 hours, and a lot of people with high sugar gets taken and stuff. So, just interesting to reflect on the fact that, we're asking people to determine within their own right, in their non-medical training, without any numbers, to make a call whether this is an emergency or not. Yet we can't most of the time, whether it's pre-hospital or when they get to hospital, we can't even work it out. Say, I don't know what's wrong. You're a bit off. Go to short stay for 12 hours and see if anything worsens.
Yeah.
So I think
it's
we're
interesting
asking
because
a
it
fair
comes,
bit, yeah.
and this is a nerd comment, so it's appropriate for your podcast. Whilst it might be a little bit boring, it doesn't speak to clinical practice day to day. Across the health system, our risk appetite question hasn't been answered. So we haven't decided what our threshold is. Now, if you're a patient,
Yeah.
the risk appetite 0, and rightly so. Like I don't want to go to a doctor who says to me, look, it was 20% chance we get this wrong and, you lose a limb for your, the mole we're going to cut out on the top of your leg. You're like, oh, I don't know if I'd accept those odds. And so we don't know. I wouldn't profess to have an answer on what the risk appetite is. So, for example, you say a patient goes to short stay for 12 hours because they go, well, my risk appetite for that patient is 0, and or at least it's 0 up until the 12-hour mark, where you can stay in and have a cup of tea and a sandwich in short stay, and we'll see what happens, I guess, because we've got diagnostic uncertainty. Diagnostic uncertainty is the life of the paramedic. That's it, and you can see why the risk appetite is low, because you go, well, you've only got to see a couple go bad when you've made a decision that maybe wasn't, in retrospect, the right decision. But unfortunately, that's part of the resilience requirement, I think, of working in the out-of-hospital and pre-hospital environment, is you have to go, I am going to make the wrong decision in this job, and there's a reasonable chance that could lead to some adverse outcomes. But I should spend a lot of my professional time doing the best to avoid that. But that, unfortunately, in today's system can't be take everyone to hospital. We have to kind of move beyond that. It's hard.
And the culture has got to change, that people, they need to get a pat on the shoulder if they do something with a bit of risk and it turns out good. I mean, you never hear about well done for not transporting that patient and preventing clogging up the healthcare system. If the boss rings up, it's only about something you missed or you should have done better, isn't it?
So true. Look, it's one of the other great limitations of practice across the world for paramedics is not knowing the outcome of your patient, so that you can reverse engineer the process to say, okay, well, I didn't know what was going on. And then they do get an eventual diagnosis. They may not, but let's say that they do, and it's some complex, Shepard-Lawson syndrome that you'd never heard of. Well, how are you going to pick that next time? Because you've got no pathway that says, well, what were the diagnostic features that I did or didn't see that led to the outcome? And it's one of our great challenges. There's a lot of privacy legislation that gets in the way of that we're continually trying to overcome. London Ambulance Service have just kind of come through a really good improvement strategy to do that for their staff. And I think if you ask the general public, would you be happy at the majority for paramedics to know your outcome so that they can use that as part of their ongoing education to understand it? That most people in the general public go, of course, because when they come to me next time, I want them to get it right.
That's fantastic. That's a really good idea. I think a lot of paramedics would get a lot of benefit out of that, and obviously help them evolve as clinicians so that they can sort of predict what they're assessing and actually work out a diagnosis. And I know recently you had a podcast chat about, do paramedics diagnose as well on your clinical conversations too. So well worth having a listen. Those that don't already listen in or tune in, look for clinical conversations on any of the podcast streaming things I think you can get. I reckon this is the longest I've chatted to you without having a beer in our hands. So I know you're a busy man and I know we need to cut this short. So I'm going to fire a question at you now, mate. And I want you to think about Junior Ben Meadley. What is something that you would like to know as a Junior Ben Meadley before coming the Senior Director of Paramedicine that you are?
I think, look, it would be to stop and smell the roses every now and again. I think it's important because I kind of raced through, as you did, Matt, we raced through our career to get to where we were, not necessarily deliberately. A lot of it was circumstantial, opportunities come up and you take them. And sometimes there's just no better or worse time to do something. It just happens. But I think it comes down to this idea of gratitude and having an amazing job and stopping every now and again. This may sound completely ridiculous, but when I look back at things, it's like, for me, the moments of reflection to say, I could be doing some kind of other job that isn't as fulfilling any day of the week. And the time that I actually took to do it were actually physical observations. So you reflect on good patient care episodes, but the times that I took to do it, and I should have done it more, is washing the ambulance, which sounds completely ridiculous. But when I was coming into the job, the ambulance is what you see. That's the thing that defines paramedics. It's the truck is what you see, and then you see a couple of people get out of it and do the stuff. And when I was working in Sydney, we at this particular station, we had 3 crap ambulances and 1 really new, awesome one. And when I was washing this really new, awesome ambulance, you know, you just go, this is a pretty good job. You know, I'm here washing this ambulance, and I'm going to be proud to take it down the street and give somebody some good care. And that kind of carried through right through to the helicopter. And the time that I did the equivalent was during winch training, because you'd be sitting down, you know, the helicopter, you get winched up and down the middle of the night in a field somewhere in Eastern Victoria as part of your training, you know, every 6 weeks. And the helicopter would fly off and do some laps, do whatever the pilot stuff that they do, and they come back and get you. And I would actually just sit there under the helicopter as it's coming over the top of you and just go, you know, you can't really believe somebody's actually putting money in your bank account to do this. It can't be real. And it was just the physical presence of that. There was that moment to stop and reflect. So for me, for junior paramedics and even myself, is just take the time to stop and reflect. And you go, it can really burden you a lot of the dysfunction that you see, one, in the organisation you're likely to be working for, the organisations that you're involved with across the healthcare and emergency services areas. That can be really challenging, large organisations to work for. The patients can be highly variable, as we've spoken about, and you might not get a vocational purpose every now and again, but you've got to stop and just go and reflect every now and again and go, there's a lot of other things I could be doing to try and earn money that aren't even near this level of satisfaction. It doesn't mean this job's for everyone. There's people where that won't be enough. I get that. But if you can stop and reflect every now and again, it is a privilege. And for me, it was recognition of some of the physical things that go, you know, I aspired to do these things, and here they are, they're real.
Very good answer, Ben. Well done. I fully agree, mate. Stopping and smelling the roses is a very good approach to this job, and having pride in your workplace that you work. I spend all my time in the car, as you do, I'm sure, most of the time. So my car is neat and clean. You know, I always keep it washed. The inside of my car is always neat and clean because that is my work environment. Having respect for your working environment is really important. Alex, last question from you, mate, and then we'll have to go because I'm sure Ben's got this meeting he's got to attend to next. Fire away, Alex.
Yes. Well, I was going to ask, how would you study medicine if you had to go back? You got all the knowledge and tips and tricks you got now, but you had to go back to year 1 at uni. Is it memorizing GTN contraindications on the back of the toilet door, or is it understanding why certain things happen, or how do you learn this big field?
For me, my approach was a bit of a hybrid. I was very immature as in my early 20s from a, I guess, focus on spending the time embedding myself in good study protocols, if you like. And it was because I didn't know what I wanted to do and I wasn't passionate. And luckily, by the time I got into paramedicine, I'd already done an undergraduate degree. And it wasn't until the 3rd year of that undergraduate degree that I finally worked out how to study. And the reason for it at that time was because I wanted to finish that degree and move on to the paramedicine. So for me, it became relatively easy to move into the study of paramedicine because I did have quite a bit of foundational anatomy and physiology. So that stuff was fairly straightforward. So I was very, very lucky then. But for me, it was a mix of going, I want to know everything I know. I want to know about the drugs and protocols as I was studying at the time. So I did learn them by rote. And I had the capacity to do so because they were fairly limited. So I did learn all of those things because I just didn't have enough foundational or experiential knowledge. So I think you have to phase it. So in phase 1, you know, I guess if I look at it, it's foundational knowledge. You go, all right, I need the expertise. I need the rote knowledge, because when I go out to do the job, I'm going to have to, you know, just pull on memory. I'm not going to pull on experience. The next phase as I moved into being a critical care paramedic, for me, it changed a little bit. It was little bit more looking at the evidence base and tying that into practice, looking at advanced concepts, getting advice from other people who've got more experience and spending more time with experts in the field. But for me, it was, again, a lot of reading, a lot of rote learning. My wife of more than 20 years can still state the contraindications to pancuronium, and she's not a clinical person, but she just tested me and tested me and tested me. We don't even use that drug anymore. And she still knows those because she had just done them so many times. So just repetition for me works. And then as I moved into, I guess, this last phase of especially research, it's just querying the knowledge base, querying the knowledge base, querying the knowledge base, going back to foundational work. But for me, the bonus is all the way along, I've taught. So I've been able to, because when you're teaching, you've got a requirement to hold the knowledge so you can answer people's questions. So is the key, I guess, to my continual knowledge is teaching, because you always do, lesson preparation, revisit concepts. And if I have an absence of teaching, you lose that information pretty quickly.
Students have the best questions.
Yeah. And when I learned the most, that's when I was teaching the cardio-resp unit with you.
Yep. Yeah,
you were teaching me.
times,
I'd sort of made it out to look like I was teaching the students, but I just sat down and asked you the questions that I thought they might have, and you come with the answers. So now that's great. Hey, have we got to finish? You got to go, don't you?
Yeah.
We'd have to have you back, mate, because
I can do this. I can do the staying alive. That's the best you're going to get from me.
Show me the worm. You've got the worm, haven't you?
The worm. I don't know about the one. The lawnmower, the sprinkler.
Yeah.
I can do that.
Here we go. Nice work, Ben. Thanks again, mate. Really appreciate your time.